Welcome to Movie Give by Interrupt Hunger. I interview experts in exercise, nutrition, and food insecurity. People who've transformed their lives through healthy habits, and community health workers building healthier communities. Our goal? Bring these proven methods back to Bernie and make it the healthiest small town in Texas. Then share these blueprints with you to create healthy small towns all across this incredible country. Before we get to today's guest, here's a quick message about our Donate Your Weight program, which helps you celebrate your weight loss victories by asking you to donate $1 for every pound you lose to help fight hunger in your neighborhood.
If you've ever said, I know what I need to do to lose weight, I just need to do it, then this challenge is for you. We help you turn your knowing into doing. The Interrupt Hunger 12-Week Weight Loss Challenge is a plan to help you lose weight by creating healthy habits in a fun and easy way. While you create new habits, we use compassion and community to help you stay motivated long enough for your new habits to stick. Bring the 12-Week Weight Loss Challenge to the places you live, work, and pray. Once a week, come together to exercise as a team in your neighborhood or at a local park. Then, once a month, come together to give back to your community by volunteering at a local food bank, food pantry, or soup kitchen. And finally, once a month, donate your weight to celebrate your weight loss victories. Donate at least $1 for every pound you lose to help fight hunger. 100% of proceeds benefit a food pantry in your area. You already know exercise makes you feel better. You already know the difference between healthy and unhealthy eating. And you already know it feels really good to give back. The Interrupt Hunger 12-Week Weight Loss Challenge helps you to be intentional about how you move, eat, and give, and helps you turn your knowing into doing. Visit interrupthunger.org to join as an individual or start a team. Contact us with any questions. We're always happy to chat.
Hey everyone, welcome back to the Movie Give podcast. I'm Bill Jolly with Interrupt Hunger. Thanks for joining us today. We've got back Dr. Evan Nadler. Thanks for joining us again, sir.
My pleasure, Jolly. Anytime.
We had a really good deep dive into sick fat and adiposopathy and all kinds of topic that really went into, there's plenty of science in that, but also went into the healing aspects of obesity and helping folks. So thanks for that, and thanks for joining us again.
Yeah, well, I think the more we talk about these topics, the better people will understand them, hopefully. And hopefully the less stigma, the less bias, the more, and the less, frankly, self-blaming, shaming. So we can just move on to dealing with the problem at hand rather than, I used to tell my patients all the time, I don't really care how you got to my office or how you got here or how you got to this weight or size or degree of disease or whatever, however you want to describe it. I only care about what we're going to do from now moving forward. Like, let's just go. Like, yes, stuff happens and it sucks that it happened to you, but time for us to just move on. And I don't mean move on in a bad way. Like, obviously, like, I'm not going to ignore your past, but I mean, like, I think it used to give people, as you can imagine, children and families didn't love coming to a surgeon's office to talk about obesity. So it gave them sort of like a, listen, I'm not going to judge you at all kind of backdrop. And we're just going to, talk about how we can move forward and hopefully get you healthier together. Anyway.
So today we're going to talk about childhood obesity, what you've spent most of your professional career focused on and helping folks. So I think a good place to jump off might just be childhood obesity or adult obesity. Seems very different. So why don't we just start there?
Sure. And because I'm getting old and can't remember things I say, and I say a lot of the same stuff from time to time, if I repeat myself, just stop me or just smack me, reach out through the screen and
You got it.
But I like to make I've made the joke before, and I like to make the sort of tongue-in-cheek joke that I would change the name of obesity as a disease to something like weight gain spectrum disorder or some like catch-all phrase, because not only is developing obesity in childhood likely different than getting to that stage as an adult, but even within subsets, even within adults, within kids, people get there in different ways. So obesity is what's called a phenotype, which means that the way it looks on the outside. So it looks on the outside the same to all of us, right? We look at a person, they look like they're at an unhealthy weight. We then immediately judge them and think that we know what they should do to make themselves healthier, which is totally wrong. But the reality is that there are different ways that people get to that point, whether it be things like radiation to your hypothalamus, to your brain because you had a brain tumor, or it could be that you have such a high genetic predisposition that it didn't really matter what your behavior was, you were going to be sunk from the get-go. Or there are mental health reasons like adverse childhood experiences that can lead to obesity. So I think the main difference, getting back to your original question, between childhood obesity and adult obesity is that children with obesity generally have a much smaller influence of their behavior, their eating behavior or their exercise behavior. They're much more likely to have a high genetic or epigenetic predisposition, or be the child of a mother who gained excess weight during her pregnancy or had gestational diabetes. Because, most of my kids, when I would see them in the office, it wasn't like they were having a diet that was different than the average kid their age, or didn't exercise initially until they got to a point where they couldn't any less than the average kid. Like it just was very clear to me that this was not an environmental or a post-birth environmental disease. This is something that they were fighting from the get-go. And then the second major difference, which may be even more important, is that the obesity-related diseases progress faster in childhood. And there's some diseases in childhood from excess weight that don't even exist in adults. So it is, I don't know if it's a different disease altogether, but it's certainly either a more aggressive form of the disease, or some people like to say it's a purer form of the disease because of the lack of environmental impact on it. But it's a thing. It's I think, unfortunately, it's what most of the current sort of quote unquote pundits or experts who haven't had that experience taking care of children don't understand. And they just have no concept of how there's a huge chunk of the American public where what they eat and how much they exercise has almost no bearing on their obesity risk.
Why is you said it's more aggressive or faster onset? So why do you think that is?
Well, it's a good question. And I think, so when I say that, I mean, as an example, child with insulin resistance due to their weight is likely to develop type 2 diabetes in a shorter period of time than an adult with that exact same degree of insulin resistance and maybe the exact same size or BMI. Why? Again, it's probably due to the genetic drivers. They're only, we don't know exactly, but my guess is that the fat cells themselves either more dysfunctional and thus they have a bigger impact on what's going on in terms of health-wise, or something in that sort of thing. Because, in general, diseases that are caught earlier should be easier to treat because they've had less time to do end organ damage. And that is true in kids too. But if you don't treat it in kids early, then they get to the bad places more quickly, which again is kind of weird, but it's a, this isn't just me. This is something that like the whole pediatric obesity community knows about and has published about. And again, I think, there are 140 million adults with obesity. There are 15 million children with obesity. So the 140 million are 10 times more or less. So they get more of the airtime and more of the attention. But in my view, the 15 million are actually more informative because they're the ones who have gotten this disease earlier and can be sicker. And thus, I think that in many ways, they're more interesting to study. And then if we can understand what's going on with them, then I think we can understand that can be generalized to the adult population.
Yeah, it's, I know you're really big on blame and making sure we don't blame. Well, the inverse of that.
Thanks. I know you like to blame your patients.
Yeah, sorry. You're quick to call out blame, even if it's self-induced or whatnot. So we see an adult that has obesity and we put the blame on them, their willpower, their discipline. And of course, there's countless reasons why we shouldn't do that. With kids, though, we seem to put the blame on the parents.
For sure. And that's unfair as well, obviously. Again, it's not, I can't remember. So I've probably taken care of thousands of children with obesity. or maybe certainly over 1,000, I think thousands plural, and 0, probably, maybe 1, maybe 2 are related to bad parenting. And yes, occasionally there's a parent who is giving their child, soda in their daily, sugar soda in their daily diet at a young age. And, that's usually due to external forces like cost or, there's usually a reason for that. And again, I wouldn't call that bad parenting. I would call that, like either sometimes it's lack of education, sometimes it's lack of access. There's socioeconomic factors. But in general, parenting contribution is small. There was one study, actually, when I was back at NYU 15 years ago, 20 years ago, that showed that a parenting intervention had nothing to do with obesity at all, but just teaching people how to sort of deal with kids who are acting out or whatever had an impact on that child's risk of obesity.
Oh, wow.
Which was really interesting because the study had nothing to do with weight. That was one of the outcomes that they found. So it's not obviously completely irrelevant. Like if every time your baby cries, you stick a bottle in their mouth, that's probably not a good habit to start and probably not going to be good in the long term. But again, that's usually because the parents are stressed out or don't have support or whatever. So yeah, I don't blame anybody. I think that's not a useful way to treat people or patients. And I try to get past that and sort of just, there's often a emotional catharsis when I make that very clear to the families who are in my office seeing me. Usually there's you can feel the burden lifting off the parent or the kid or both. And occasionally, depending on how the room is going, I might blame the genetics, which blames the parents. But, that's not, I don't usually start there because I usually want folks to feel good about themselves in my office. And then it just makes for, I think what's it called? Model. Anyway, it makes for a good care model where everybody's involved and can come together and make suggestions that everybody feels good about.
Yeah, sure. And they're there. I mean, so let's see here. What about ages? What's a typical age and age range? And then like how young would you see patients?
So, the youngest patients I've ever done bariatric surgery on are in the 4 and 5 age range, which usually makes people go, what? But those kids generally have what's called monogenic obesity. So they actually have a single gene defect that causes them to gain weight. And I learned, what was that? I think 10 years ago or more, where I saw my first patient with monogenic obesity. And at that time, I wasn't really willing to do surgery on a 5-year-old. And then I waited 2 years and that same kid went from being fairly functional, although having severe obesity, to being wheelchair bound due to her weight and not being able to take care of herself. And so I finally did her surgery and she's done really well. But I said to myself, well, if I ever see this kind of thing again, I'm not going to make that same mistake. I'm going to just do it. So thinking I would probably never see a patient like that again because they're pretty rare. But then then a family came over from the Middle East that had several kids with the same sort of gene defect. And I ended up tackling them earlier and similarly, they did pretty well. Now, even kids without a single gene defect, I've seen as young as 8 or 9 with type 2 diabetes from their weight. And so I have before I stopped a couple of years ago, I had the country, and probably still do because no one probably is as aggressive as I was. But I published my experience of kids younger than 12 and under, preteens. And I have done more of those than anybody in the country. And they actually do really well for the most part, although, again, they have the strongest genetic drive to gain weight because if they need bariatric surgery at such a young age, they got something else going on than the average person. Yeah. And then I would see up to age 25 or so, especially if they have diseases that are more commonly treated in childhood, like Down syndrome or autism spectrum disorder. I've published a lot on autism spectrum disorder. So I like to think of myself as the doc who will take care of the kids that everyone else is somewhat apprehensive to take care of. Like I'm just a guy from New Jersey who just wears his emotions on his sleeve and basically is willing to try I'd rather try something and fail than not try at all, because you don't try at all, what have you accomplished? I mean, we know for most of obesity care, if you don't do something, it's going to get worse. The obesity is going to get worse. So I always just explain the risks and benefits to each patient and family and let them make the choice. And actually, when I first, with the 4 and 5-year-olds, I would tell those families, I said, listen, no one knows whether this is going to work for your kid or not. I'm willing to try it because I know I can get your child through the operation safely. But honestly, I have no idea whether this is going to work. And then over time, I figured out that it actually can work, and can work pretty well in the right circumstances with the right support and everything else. And again, I'm not saying that that's what everybody in the country should do, but I am saying that for some specialists, it's actually a reasonable thing to
Yeah. So for the younger kids, it's easy. It's the parents are going to be the driver to come in and see you. But when kids start getting like a little bit older, 14, 15, 16, 18, it could go either way. So for those older teens, who's usually pushing the visit to you?
Yeah, so it's been really interesting to watch over the 20 years of my career. So in the early days, when I first started, my typical patient was the child of someone who underwent bariatric surgery. And that parent, often the mom, but sometimes the dad and sometimes both, would just come in and say, my child is going through the same thing I went through at 13 or 14 or whatever age. And I just don't want them to have to go through their adolescence the way I did. And, I didn't know bariatric surgery was an option in teenagers, but we found you on the internet and, can you tell us about it? So that was my typical patient for, I don't even know, let's say 5 years, until word started to get around. And I never advertised my program. Those guys who was like, selling something. And so, as you can imagine, a lot of those teenagers posted their positive experiences online. So as my program progressed, it would be, more coming from the medical docs, because they would see these patients post-op and how well they would do. And they were skeptics in the beginning too, because everybody was a skeptic. So I get more referrals from them. But then also there would be a lot of teenagers who would find me first, doing their own internet search for help. And then they would have to convince their parents that it was okay to come see me. So I actually did sort of start a lot of my, like, as things progressed, I would start a lot of my visits with, so tell me how you found me. Like, who directed you to me? Because if the kid said, well, I found you online, but this parent over here, they're not sure that this is a good idea, that actually would change how I would approach the visit. Or vice versa. Like if it was the parent, but the kid was kind of reluctant, because that happens too.
Yeah.
I would, that sort of visit, I'd be like, okay, well, no one's deciding about surgery today. Like, this is just purely an informational visit. And, if you're speaking to the kid, if you're not interested, that's fine. Don't worry. You're not going to hurt my feelings. We're just here to chat. And then if it was the other way around, if it was the kid who found it and the parents were skeptical, that would be the room where I'd be like, well, it's actually your parents' fault that you're like this, because they gave you the genes. They gave you the genes that put you in this situation, and you're just playing the hand you were dealt. Like, you got no choice in this matter. So if you're going to, so feel free to on the ride home, give your parent a bunch of grief. Of course, joking. And again, just trying to take the tension out of the room is always key. It was always a key piece of every visit with me, is just trying to get past that I don't want to be here, moment, because almost everybody comes in, except for when the parent and the kid were on the same page before they got to me. And then they were both excited to get to me, because they both were just happy that someone would treat their disease as real and as not a lifestyle choice, and just give them options on how to move forward. Like, those are sort of like obviously the quote unquote easiest visits, because the folks would come in sort of together with the same idea for game plan. And so there wasn't a lot of time spent like necessarily convincing or breaking the tension or whatever. It was more like just down to business. But I never miss an opportunity to tell bad dad jokes or bad obesity doctor jokes. So I still throw them in there just because they entertain me.
And the kids love it.
Yeah. They roll their eyes.
Yeah. No, that's good stuff. Does what about the socioeconomics of your patients you saw? Because a lot of people still don't realize that like our most vulnerable, the ones that have the most social determinants of health stacked against them, are struggle with the much higher rates of obesity and chronic disease. The ones that need it, like does Medicaid or cover
Yeah.
cover those
So,
folks?
right. So that's a great point. And first, I want to make sure that everybody understands that obesity crosses all age, crosses all socioeconomic strata. It crosses all races and genders and ages. So yes, people of color and people with socioeconomic challenges have a higher incidence of obesity, but it can happen to anybody. And I've seen the richest of the rich and the poorest of the poor, but it has progressed over time. And I spent a lot of time in my early days in DC working with the DC Medicaid, Maryland Medicaid, and Virginia Medicaid to make sure they did pay for it. And not all states do, especially in the under 18 age group. But it was always part of my sort of advocacy work that I would either talk to the medical directors or even I have a couple of big wins from my early days where a couple of private insurers, I got them to change their policies to include children under 18 in their coverage. Even the military, I got to change their policy towards the end. That is obviously the hardest to do. As you can imagine, the federal government's always the hardest to convince of anything. But yes, and the reason that I think the Medicaids, at least in the DC area, were quick to adhere or quick to cover it, is I explained to them the finances of how it all works. So in adults, the break-even point for bariatric surgery is about 3 years. So if bariatric surgery costs, let's say $25,000, that's similar to 3 years worth of expenditures for someone with obesity who's not getting treated. So if you do bariatric surgery and their comorbidities resolve after 3 years, it's actually a financial win for the Department of Health for the state and the taxpayer. In kids, it's probably not 3 years. In kids, it's probably closer to 5 to 7, depending on how sick they are. But another one of the pieces of data that I think that the Medicaids do understand, at least some of them do, but maybe not everybody, is that people with obesity tend to have hurdles in their job, career, advancement in general. And so they end up either staying on Medicaid longer or staying in jobs that don't offer healthcare benefits longer. So there's this whole hidden morbidity of obesity that people don't talk about. But again, so the Medicaids, so they sort of know that if you're a 17-year-old, 15-year-old with obesity, you're likely still going to be on that Medicaid when you go past 25. So they want to intervene sooner rather than later because their cost savings will start sooner rather than later. So I think, so Medicaid's, again, the Medicaid's coverage varies from state to state. I'm actually sitting in Pennsylvania right now, and the bariatric surgeons I've spoken to in this state say that while Medicaid does cover it, they don't reimburse the hospitals at a significant enough rate to make it worth the hospitals to want to have bariatric surgery programs for people on Medicaid. It's all, it's completely variable. Some states didn't cover it. Some states didn't cover it under 18. It's all moving, and same thing actually goes for the weight loss medications, right? So some states will cover the GLP-1 agonists, some states won't. Some states won't cover them under 18. Some states will only cover them for diabetes, but not for weight management. So it's just a mixed bag. I actually had an administrative person whose job it was for every patient who came to see me to actually figure out what their insurance benefits were, because it's such a hurdle. And it's probably one that they introduce on purpose because they don't want people to get access to care, which is a whole nother advocacy effort.
Know a lot about that. What about, so I've heard you say several times that you're treatment agnostic, which I love that approach. I think some folks might hear that you're a bariatric surgeon and, so you have a hammer, everything needs a hammer, right? And that's not the case at all. So talk to me about success rates for different treatments for kids compared to adults, if you could.
Yeah. I mean, the first key point in that is, how do you define success? And the success for, let's say, the insurance companies is different than success for patients, right? So I would say success, and each person has their own definition of success as well. Like if you start a GLP-1 medication and your A1C gets to be completely under control, but you don't lose a ton of weight. Is that a success or is that not a success? Sort of depends on the person who is taking that medication and what they were hoping to get from it. So, and in bariatric surgery, because a lot of surgeons are numbers oriented, there's people use 20% total body weight loss as a cutoff for quote unquote success, which again, to me is sort of, I don't know, to me it's arbitrary, because if you lose 15% only, but all of your medical issues have gotten better, why isn't that okay?
Sounds like a win.
Right. Or if you lose more than 20%, but we didn't fix your dyslipidemia or some other thing that was really important to you, is that a win? On the flip side, and I actually, there are definitely patients, among the saddest patients for me would be the kids who would come in with mental health issues in addition to their obesity and physical health issues. And I would explicitly say to them, surgery might fix all your physical issues, but it may not help your mental health issues at all. They may, but it may not. But everybody, including teenagers especially, don't always hear exactly. They hear what they want to hear, and sometimes than what you're telling them. So I'd have kids who would come back and they would have lost a fair amount of weight, but would be even maybe more depressed because they really thought that the weight loss was going to fix their lives, and it didn't. And those were like amongst the most heartbreaking patients. So I worked with an awesome child psychologist when I was in DC. She's still there. And we would have a lot of conversations about the different kids we would see and how we can best help them all, because, it's such a, high school is hard enough, adolescence is hard enough, and then going through it with chronic disease like obesity is hard. And then even when you get bariatric surgery, let's say, and you start losing a lot of weight, it sometimes gets harder because then everybody wants to talk to you about your weight. Everybody wants to say, oh my God, you look so great. How did you do it? And you may or may not need to want to share that. And so that was another thing we learned along the way, was like, we had to prepare. We had to tell our kids before surgery, listen, this is going to happen to you, and you have to decide yourself, and it's a personal decision, who you want to tell, who you don't want to tell, what you're going to tell people. Like, and then there's the whole, especially when we first started, there was this whole concern about the increased sort of social attention, dating attention that especially the girls would get when they would lose weight, and they, might never have had any attention before, and now they're getting all this attention. There were pregnancies along the way in the early days. In fact, one of the programs used to mandate birth control when they first started, which is like draconian if you think about it.
Yeah.
But that was part of an NIH-funded study, so I could do that. But in the real world, you can't really tell people, you have to get some sort of birth control, or I'm not going to operate on you. That doesn't really work. Luckily, we've come a long way in the sort of 20 years plus since we've been doing bariatric surgery in children. We've learned a lot, and things are getting better for sure.
So, you mentioned a couple of things that you worked so closely with a child psychologist. I'm a huge proponent of mental health therapy. We've all got issues. Just some of them choose to deal with them, and some don't. There's been I don't know if stigma is the right word, maybe, but that insurance required you to get counseling before you went through surgery. Is that still the case, or is that changed?
Yeah, it's an interesting topic, because in the beginning of bariatric surgery, yes, every patient had to get a mental health clearance for surgery. And that clearance was supposed to assess, like readiness for change, readiness for surgery, make sure the patient wasn't using any illicit substances, make sure there wasn't a suicide risk, all these things. And in the adult world, the American Society for Metabolic and Bariatric Surgery has been fighting that requirement, because it's somewhat, as you said, stigmatizing. It's the only procedure or treatment that I know of that you have to get cleared by a psychologist or a psychiatrist in order to get. Seems kind of...
I had major ankle surgery in January. It was almost 3 hours. I mean, just picturing before you get your ankle surgery, you need to go talk to a counselor. Like, that's just dumb.
I mean, I mean, maybe it's good because maybe everybody should talk to a counselor anyway, but that's not the point. So it remains a hurdle. I mean, it remains something that insurance companies require. I do think it's important to have conversations again, especially in the children, about how you're going to deal with the aftermath of your weight loss or while you're losing weight, or what are you going to do if you don't lose weight, like, coping strategies. So I think there's value to it. I wouldn't necessarily advocate for it being a hard requirement, but I would probably, and a lot of people, to be honest, would do what they need to do to get to surgery. And then whether they followed up with the mental health professional or not, it was on them. So a lot of people didn't. And there's no way, once you get your surgery, there's no taking it back. So it's not like we could chase them down and say, we're going to put your stomach back in unless you go see your psychologist. But yeah, I think, it's probably going to be there forever because that's how it started, and it's going to be too hard to get it removed. But whether that's fair is a complicated question.
Yeah.
But like you, I think everybody, I mean, if you're undergoing major health issues, you have a chronic disease, you're going to potentially undergo a therapy that will, change how you eat. It helps talking to people. And the way our team worked was really, we almost never said no to a patient who wanted surgery. We might say not yet, but we would almost never say no. It would almost always be, listen, you're not ready right now because you're dealing with, but if we can get you to a place where you're stabilized, then we can go. So again, that's sort of more my philosophy, is just, it is important to make sure people are ready, people are best prepared, but I don't like to say no.
Yeah.
So we work together to try to say yes.
Were there certain behaviors, certain things that could increase the likelihood of that quote unquote success? I don't know. Maybe we need to phrase that differently, but yeah, more positive outcomes.
Yeah. So I think it's easier to predict the negative outcomes. Although one of the reasons my psychologist and I worked so well together is that when I got to DC from New York, I'd already been doing bariatric surgery for 5 years. And I told her and everybody else that nothing preoperatively predicts postoperative outcomes. So we should stop using those criteria as a hurdle or something. Like if you're not exercising, like saying to somebody, you have to exercise 3 times a week or you're not going to get surgery.
Yeah.
None of that mattered. And we've studied. So my psychologist was like, okay, I believe you, but I want to study them all again because you were doing lap bands at the time and we're going to do a different surgery and we should study. It's like, okay, fair enough. And so after, like 3 or 5 years, when all the data came out and again, nothing preoperatively predicted postoperative outcome, it built a lot of trust because obviously I didn't say I told you so, but I wanted to say I told you so. Yeah. Maybe I did say it. So certainly people who already have made dietary changes and who are already exercising a lot, one would logically think would do better after surgery. And they possibly do. I think the reason the data don't necessarily show that is that you need such a huge number of patients to, if you have just one patient who doesn't do well, it can skew the whole data set. But on the flip side, like we did try to tell, like if somebody was continuing to drink sugar sweetened soda, that might be a patient where I might be like, listen, I'll get you approved for surgery, but I'm not going to actually do the surgery until you've at least made an attempt to stop drinking smoothies every day or, Coke every day or whatever. But the reality is that, again, like they could do that just to get surgery and then you have no control over what they do after surgeries. But similar to the GLP-1 agonists, bariatric surgery is weird in that it changes your sense of smell and it changes your sense of taste and it changes your food cravings to a degree. So I have patients who, after surgery, their dietary patterns changed drastically. And it wasn't just because they had surgery. It was because they're, like I had one I like to talk about is a patient who was really mad at me because before surgery, she loved crawfish and after surgery, she hated them. And I was like, I don't know what to tell you. I'm sorry.
Yeah.
And then, other patients who I remember a patient who said that she couldn't even stand to be in the room with someone who was drinking milk after surgery because the smell of it would make her nauseated. Again, I mean, I have no idea why. Um, but it's real. I mean, like people have studied it. It's like a real phenomenon. And it probably speaks to the gut-brain axis and a whole bunch of things we don't understand. It probably is part of the reason why surgery is more sustainable, or the weight loss from surgery is more sustainable than medications, because we probably do something more permanent to alter the gut-brain axis than is done with medications. But it's still totally unknown. And we've been doing bariatric surgery pretty much for 30 plus years now, and we still don't really know. So,
The two things, kind of both sides of it. What is the success rate? Okay, I still don't like that word, but yeah,
no,
what is the I'll go with it. I don't know what else to use right now. What's the success rate for bariatric surgery versus GLP-1s and lifestyle?
sure. So most of the data are from adults. So I'll give you those numbers first, because that's where it's mostly been studied. So in adults, about 20% of people after bariatric surgery will regain some or large fraction of the weight they've lost from the surgery, unless you do something to stop it. So about quote unquote 80% do well, 20% have weight regain. With meds, the numbers are sort of flipped. About 80% of people who stop a medication regain weight, and only 20% are able to keep it off long term. And then diet and lifestyle is the least successful of them all, which is 95% of people who stop their diet and exercise intervention regain their weight. So, and those are from adults, and those are pretty big numbers and pretty well established numbers. And it's why, in many people's opinion, surgery is still the most effective long-term weight loss solution. Now, in kids, the lifestyle data are basically the same. 95% regain their weight. The medication weight regain rates are lower. And then there's some really interesting data that the Teen Labs Consortium recently published, and they're working on longer follow-up. But at 10 years post-surgery, those patients in their cohort still had a health benefit and were able to keep the weight off. But and they had a lower 10-year recurrence rate of diabetes in their cohort was lower than 7 to 12-year diabetes recurrence rate in adults. And that was true even if people regained some of their weight. So the data suggests in kids that they have longer benefit and more benefit than bariatric surgery in adults. And they're actually working on their 15-year follow-up data now. So in my personal experience, nowhere near 20% of my patients regained weight. I mean, I did 750 bariatric cases in DC over the 15 years I was there. And so that would mean that 20% would be 150 of those patients would have had to regain weight. And
Yeah.
there was no way we were near that.
Why do you think that is? Why do you think kids are more successful of keeping the health issues in check than adults? Is that, like you were saying, a 5-year-old doesn't really have the behavioral aspects, like the habits, the environmental?
Yeah.
Is it ingrained?
Yeah. I mean, I think for sure. Well, short answer is I have no idea. The longer answer is I can speculate and give you my suppositions. And I assume that, so one of the things that's been shown recently is that fat cells have memory, and that they basically get epigenetically modified, so that even after you intervene with surgery or medication, they may work against you in the long term. And so my scientific guess is that when you get to surgery sooner rather than later, those epigenetic modifications are fewer, and thus the benefit is more long lasting, because the memory of the fat cells, and probably other cells in the body too, it's probably just not the fat cells, aren't working against you. So that's my sort of potential scientific explanation. From a behavioral standpoint, it may certainly be that. So when I was at NYU doing lap bands, I think they had an interesting study where the people who did the best with bands were the people who had the most to benefit socially, whether it meant new job or new spouse or something like that. And it's possible that it's the same thing with kids, right? Like a kid who gets their life back because they're now healthier and closer to normal weight, can participate in all the social activities that every other kid gets to participate in, they may have more of a social imperative or drive or desire to keep that weight off. So they may work harder to do it. I'm not sure that that's true, but one could sort of see why
That
that
makes sense. Yeah.
could be true. So, that's probably like everything else, a combination of those things. I do think that, at least in our program, we did a pretty good job of finding the kids who were falling off the curve and getting them back into care and intervening usually with medications after surgery if they started to regain any weight. And I think the adult community is going that direction as well, where people are starting to understand that the meds and the surgery actually work better together than they do separately. So it could also just be an evolution of care in general that we're seeing that we're starting to understand more about it and starting to work together better. Like it's no longer surgeons versus non-surgeons in terms of the care of obesity. So,
Partnership.
yeah. But I'll go back to my first answer. I have no idea.
Yeah. So, taking a little bit different direction, you kind of touched on this earlier, but it was interesting. So when I was editing our last conversation on adiposopathy, you were talking about weight regain from the different treatments, surgery versus meds, and then lifestyle, like exercise and diet. And it just hit me like, I think that's the most beautiful response. I'm gonna start using it every time I hear somebody say, "Well, if you stop taking GLP-1s, you're gonna gain the weight back." Well, yeah, if you're exercising and eating right, and then you stop, what's gonna happen?
Right. Or, I mean, what a lot of advocates say is if you stop taking your blood pressure medicine, what's going to happen? Or if you stop taking your statin for your cholesterol, what's going to happen? Like, why is it that obesity has this threshold that's different? Like, of course, almost any disease you have that is treated with a medication, if you stop taking the medication, the likelihood is that the disease is going to come back. Like, duh. But yeah, the obesity stigma and bias is so pervasive. It's not only socially, obviously, with what the people who have the disease have to suffer on the day-to-day living their lives. But then, they get it in the provider's office when providers keep saying the same thing over and over again, or, just don't listen to the patient and don't offer either referral to specialist or some other option. But then also, again, like the insurance companies and the medical community and no one would ever say about high blood pressure or diabetes or, high cholesterol. Well, if you stop taking your medication, you should be able to stop taking your medication. Like no one argues that. And the silly thing is obesity leads to all those diseases. So like, of course you should take your obesity medication maybe forever because you would take your high blood pressure medicine forever or your, high cholesterol medication forever. So what's the difference? What's the big deal? But haven't quite gotten there yet.
Yeah, it's pretty wild. I had a conversation last year. I don't think it's changed that much, but I did not realize obesity is not a protected class of discrimination.
No, that's for sure. It's the last accepted, well, maybe not the last current environment. We're getting to discriminate against more and more people again. It's like we're returning to the dark ages of society. But and I think what I sort of hope or maybe even envision. So first of all, most of the obesity medications were initially approved only to treat people with obesity. So if you lost weight on the medication and you no longer had obesity, some insurance companies would take away the coverage for that medication, which again makes no sense whatsoever. But I'm hoping with the oral GLP-1 agents that are coming out in the next year or so, like I could see a world where you take your GLP-1 medication, an injection, because it's probably easier to take once a week, or you take the pill, whatever you want. You've lost enough weight and you're going toward weight maintenance. People in the community have already been sort of like dialing back the doses or like doing things that are not quite FDA approved. But I'm hoping that maybe that's where the oral GLP-1 agents will have a real role, is that like you take the injectable until you get down to whatever weight is the healthy weight you're trying to achieve. And then you switch over from the injectables, which I think still are going to have higher weight loss and probably higher side effects than the pills. But maybe that's when you switch over to the pill and that becomes your statin that you take forever.
Yeah.
Pressure medication. Luckily, I'm not on one of those. That's knocking on wood. Not on a blood pressure medicine, so I don't know what the most common ones are, but yeah, so maybe that's where we're headed. That'd be great, because I do think that would make sense. And the oral GLP-1s are going to be a lot cheaper. So maybe that's where we're headed. At least I'm hoping that's where we're headed.
Well, we'll eventually get there. I don't know if it'll be in the next year or two, but I mean, just people are hungry to be healthy, and I think they're just much more open-minded and looking at things.
Yeah, I think it's sort of the double-edged sword of the internet and social media and stuff like that. Now, people are all definitely more self-advocating because they have more information at their fingertips and can sort of go over options that they might be interested in before they even see a doc. But there's also so much misinformation out there that, like, people come in with all kinds of things that are not based in science. And then, even some people who run government agencies espouse things that aren't based in science. So it's like the whole world is like a potpourri of misinformation. And it's really just like, how do you sort through what's real and what's not?
Yeah. So I got one more question to two more questions to finish this off, but it leads into your next endeavor. So you've got this unique telehealth program that you and some partners started. Tell us about that. But as you do, if you don't mind, lead into that with, when should somebody reach out to obesity medicine specialists? When should they talk to their primary care? When should they reach out to your new company, ProCare?
Sure. Well, first, you should reach out to your primary care doc or primary provider whenever you perceive or your child perceives that the weight is becoming an issue, whether it's a mental health issue or a physical health issue, doesn't matter. Like, if it's bothering you, talk to your provider, because they hopefully will be open to discussing it. And then if they don't really know what to do, they can at least refer you to an obesity medicine specialist. So our unique practice that we just started actually last week, if you look at pediatric weight management programs, they are clustered in the Northeast and the West some, but they're huge swaths of America that have no access to pediatric weight management, in large part because most of the pediatric weight management programs are located in urban centers and generally academic centers, and they are nowhere near meeting the need of the number of people who could use some help. Like, for instance, my program in DC before I left was the busiest program in the country surgically and among the busiest medically. But we had a 300 patient waiting list because the demand was so high and there was basically nowhere else for these patients to go. So my partner and I, and my partner is a pediatrician from Children's Hospital of Atlanta, she and I initially formed a company to try to hospital systems build programs because we wanted just to teach others how to do it. And we spent a year trying to convince hospital systems to hire us to help them to build access to care. And maybe not surprisingly, although I was surprised, no one hired us. No one cared. No one cared at all. Not even like lip service cared. So then we were like, well, what do we do next? Like, if we can't get hospitals to expand access to care, how do we do it? And so we came up with this telemedicine only practice. And it's pediatrics only. So, and that goes up to maybe 25 or 26. And certainly we'll talk to families as well. But but there are a growing number of adult telemedicine weight management practices. And some are now actually even seeing teenagers or maybe even younger. But we're the first in the country that's only pediatrics. Like, that's all we do. And it's not that we don't know adult obesity medicine. It's just that we feel like those adults have a lot of places they can turn to. Kids basically have almost nowhere to go. So we're just starting, but we're only starting in Georgia and Florida for now, just because of getting medical licenses in all 50 states is a thing. We want to make sure that this is something that the people want. I mean, we think it's what the people want. And there have been patients who've told me that this is what they want, but you never really know until you actually do it. But if it's successful in those 2 states, the plan is to roll it out to all 50 states. And that way, access to care for all kids struggling with their weight and all families struggling with weight issues have somewhere to go. So that's the hope. And then the hope is to take that and then go to hospital systems and say, look, you guys got to start to support this because we can't do it by ourselves. But if you as a hospital, you guys could do the same thing. Either you could hire us to do it or we could help you do it similarly so that, because it's actually more cost effective than bringing people into brick and mortar clinics. It's better for the patients because they don't have to drive. They don't have to take a day off from work. But it's also, frankly, better for the hospital systems because they don't have to pay academic clinicians fringe benefits and all the other things, the high salaries, this and that. So it actually should be a very cost-effective way of delivering care. But I guess the proof is in the pudding. We got to make sure we can do it and do it well before anybody's going to take us seriously. But that's the plan.
So it's not just surgery.
No, yeah, sorry, I didn't. It's
That's
actually
all right.
it's not surgery at all. Well, I shouldn't say that. For people who want surgery, we can get them prepped for surgery and then help them find places to get surgery. Right now, I'm personally not doing any bariatric surgery anywhere in the country, although that could change depending on how this practice goes. But let's say you're in Atlanta. We know surgeons. I know surgeons, pediatric bariatric surgeons in Atlanta that I can refer you to. Or if you're in Florida, I know people in Florida who I can refer you to who have programs that I have vetted and trust. So we're almost functioning even as like a patient navigator kind of thing, like, because it's so hard to find care and good care out there. So we're trying to not only provide the care, writing prescriptions for meds, getting the lifestyle stuff, behavioral treatments, lifestyle treatments, dietitians, psychologists, like providing all that stuff as well, but also being a patient navigator. If you need something more, we can help point you in the direction where you can get more than do. And then from the clinician standpoint, like the surgeons I talked to, I said, listen, I will get your patients ready for surgery. I've done more of it than anybody else in the country. I can definitely provide you patients who are well prepared to undergo a procedure. And then you don't have to do that. You can focus just on doing the cases and in theory, your volumes can increase because you won't spend as much time in the prep because I'll be doing that for you. So that's another, again, whether the business model works or not, I don't know yet. I'm pretty sure. I mean, I know there's a need out there. Do I know that people will come get their care with us? I don't. But I think we just have to work on getting the word out there to folks and so that they know that it's an option. And like I said, we started last week, so we got some work to do.
Yeah.
But
Well, most practices that are anything to do with weight management right now are backed up 6 months. So I don't think there's definitely not a lack of need. So I'm excited to follow your journey with you.
yeah. Well, as I said earlier, there are 140 million adults and 15 million children with this disease. So I don't even know how many providers you would need to address all those people. But it's certainly not going to be, I think, again, as we evolve, it's going to have to be primary care docs who deal with this disease because the specialists just aren't going to be able to handle the volumes of need once people realize that they should, like right now, maybe 5% of people who have obesity actually seek out care. So it's still
5%.
Well, I'm using that number is from GLP-1 from medication. Like that's about the uptick of the GLP-1 medications. About 5% of people who could get it do get it. So that may not. So it might be slightly higher for behavioral treatments. I don't know.
But still, it's not a lot. Yeah.
It's not a lot. It's certainly not. It's certainly not 14 million. Certainly not 10% of people. There aren't 14 million people out there who are getting. Who are trying to deal with their health with obesity medicine specialists, at least not that I'm aware of. So
as the bias and stigma start falling around treatment, that'll do nothing but improve as the cost of treatment comes down. The oral options, the more options we have.
And that's the goal, right? That's what we're all trying to do is make it more accessible, more affordable, less stigmatized, and just get, at the end of the day, and I've said this before, and it totally sounds sappy or corny or cliche, but it really is just about helping people get healthier. That is the goal. Like I'm trying to think out of the box in ways to make it happen because I'm a sort of out of the box kind of guy. But at the end of the day, the goal is the same. It's just, we want people to be able to get care and get care that they like and get better, get healthier. And that's why I'm treatment agnostic because I don't really care. Yes, I have opinions about which options might work better or not as well. But at the end of the day, you're the patient. You got to decide what you want to do. And I'll help you get to a decision. And then hopefully as the patient, you will have an open mind. If option 1 doesn't work, move to option 2. If option 2 doesn't work, option 3, there are lots of options. So you just got to keep at it. So,
good.
But that's my Jersey roots again. Just doesn't matter how many times you run into the brick wall, keep running into it until you can break it down. Maybe take a different path. Don't go to the same spot.
Well, this has been fantastic, Dr. Nadler. Thank you so much. Thanks so much for listening. Please rate and review the podcast on the platform of your choice so we can reach more people and more people are recommended this podcast. And if you really liked it, the single best way you can help us grow is by telling your friends. Now, for all the legal stuff. The views and opinions expressed in this program are those of the speakers and do not necessarily reflect the views or positions of any entities they represent. For my day job, I'm an employee of AbbVie and appear on this podcast on my own accord and not in the professional capacity as an AbbVie employee. All viewpoints provided are my personal opinions and not intended to reflect those of my employer. If you have any questions or comments, please shoot me an email at jolly@interrupthunger.org. Let's go spread some joy, people.